So I was asked by Imogen to talk about the value of psychological support. I think because I have published research that we've done looking at emotional responses to diagnosis. So I speak about my research and about published data, but I'm not a psychologist. I looked after melanoma patients for very, very many years, and it's in that context that I'm going to talk. Is there a need for psychological support or counselling? I would say, obviously, but this was recognised by NICE in the clinical guideline published in 2015. And we specified a number of things. Actually, it's not on the screen and very difficult to read from here, those details, and I don't have a portable microphone, so I'm not going to go through these in break. Actually, have you got your microphone, the handheld? I've got the ball. Lord. Apparently I can speak in this when it's live. And apparently, when it comes to question time... Is that live? No? Hello? Oh. Okay, so we talked about... are you going to put this on your website? We're going to talk... We had information... Oh, she is! We're going. The NICE guideline specified written information. Being able to look things up on an app would be great, I would think. But the need for written information was specified. There was a lot of attention to training medical and clinical staff generally, and the requirement is that every member of multidisciplinary teams should do training, formal training in breaking bad news. One of the most important cause of this is the recommendation that all MDTs should have specialist nurses there as the main contact for many patients between consultations. I think there can be an overemphasis on this because I don't think that caring for people and identifying the need for psychological support is the province only of the support nurses. I think it should be very much the clinician, the doctor's role as well when they're seeing patients. And at the bottom, that as well as having access to a melanoma specialist nurse, that there should be psychological support. So in my experience anyway, a proportion of patients need something beyond the specialist nurse, a psychologist. And this is from the Macmillan website about, it's a visual representation of the support that melanoma specialist nurses give many, many patients. So the first bit of our work, research we did, was trying to determine how many people worried significantly in the long term about the future after a diagnosis of primary melanoma. A lot of the research done, particularly the research that we have done, is about primary melanoma, not least because it's easier to do large-scale studies at the time of diagnosis, and because as a dermatologist, those were the patients that I was seeing. So we collected data from 2,000 patients in this particular study, and we asked them, how do you feel about the future with respect to melanoma? Actually, 75% of them said that they felt confident about the future, 25% that they were experiencing significant worry. I suppose you might think that that's a good breakdown because actually most people with melanoma at diagnosis are fine. So it suggests that there's a reasonable amount of understanding in this sample about their long-term risks. It suggests that. We found that men were less likely to, now I've put report worry, they're less likely to say they're worried. Whether they are less worried or not is not clear because, of course, men are not encouraged to say they worry, and I'll return to that later on. People worried less as they got older on the whole, although the data also suggested that if people lived alone and were not working, they were more likely to worry as they got older. And patients with advanced disease were more likely to worry, of course, than earlier stage patients. So there's some suggestion that people were having a proportionate worry, as it were. We found that people with melanoma in unusual sites, for example on the sole of the foot, actually worried more. And I wondered whether that was because actually there's less known about those sorts of cancers. There's less written information about those sorts of cancers, and they're also quite difficult to keep an eye on those sites, such as the vagina. It's quite difficult for patients to feel in control when they've had an internal melanoma. The general conclusions, in addition to those observations, were that patients who worried most after primary diagnosis were those who had many stresses, that this was, in some ways for them, the final straw. They had lots of other problems. That a perceived lack of support from healthcare teams made things worse. I'm not sure, it's just difficult to interpret some of these responses, but that was one of the responses. And if people reported previous anxiety and depression, they were more likely to experience worry. Now, this comes down to empowerment at the bottom. Patients with a high internal locus of control were less likely to worry. Now, high internal locus of control means that the patient has a sense that they're in control of their own health. So people talk about powerful others, where the patient who would say, whatever you think, doctor, people who think that their health is controlled by other people, as compared with people who feel that they're in control. It's their responsibility to look after their health. And people who had that sense tended to worry less. And as I said, maybe that relates to Imogen's taking control, psychologically taking control of your health. We did another study. This was in conjunction with the University of Manchester, and this was a slightly different study. The first study was a questionnaire study. This was a semi-structured interview study. So we interviewed 16 patients within 5 years of diagnosis with stage 1 to 3 melanoma. And we asked about those major themes, the effect that their diagnosis had on relationship and things like that. And so the dominant themes through this as a result of gathering information was, of course, uncertainty about the future. But I've put some of the quotes from this in my presentation because they, in the modern, what people say, resonated with me. It was things that people had said. So one person said, am I now waiting for something else to go wrong? It seems like you're waiting for your future. It's probably the same with any cancers, but with melanoma you're thinking now, I can only be vigilant, I can look for moles and lumps. I just feel that you're looking for things that can go wrong. Now later on this morning we're going to hear about empowering you to feel confident that you can examine your skin and lymph nodes, but actually some patients find that difficult, in my experience anyway. The responsibility for looking after their lymph glands and their moles weighs heavily with some people, and with other people it's empowering. And of course we're all different. So my own view from clinic is that what works for some people, it doesn't work for everybody. I feel a bit crap today and all that. You can't, I mean, if you knew somebody on the phone or were going to cancer hospital and you could have half an hour, but there's nothing. You're just out on a limb, really. Even though it's a cancer, there's no actual help. Well, that person felt really, really alone, didn't they? They really didn't feel there was anybody to call. And the melanoma specialist nurses play a very significant role in most units as that person that you can call for half an hour when you're feeling really down. Of course, in many patients find that same help from elsewhere, from GPs, etc. But that's a role that the melanoma specialist nurse is intended to fill. Many patients reported difficulties with body image. This is a lady who had significant lymphedema, swelling of the left leg after surgery to her groin. And lots of these patients reported problems related either to the excision scars, the lymphadenectomy, or removal of node scars. Many felt they hadn't really expected things to look so bad, look that way, and some said that they tried to cover up the scars, they changed their clothing. Some people felt that it didn't help sexually, as it were. So altered body image. And of course, one of the difficulties after a diagnosis of cancer is that things don't seem the same. You've lost a lot of your normal life if you're unwell after surgery, or if you're unwell on chemotherapy, or even if you're just struggling with a diagnosis. And changing body image for some patients, I think, is a reminder. So it's a traumatic time when you're diagnosed, and then you look at the scar and it kind of brings it all back. So it's complicated reasons for some patients in terms of how they feel about this changed body image. But body image in our culture is increasingly important to us, isn't it? Particularly perhaps, well, I think to everybody, but particularly perhaps for young people. So changing body image is difficult for many. Some people were scared to death of the sun. They didn't know quite how much to go outside, how to stay in. Actually, it's a balance. Really, you just need to avoid sunburn. You don't have to be a recluse, but lots of people expressed uncertainty about that. So we might say in clinic, now be careful, keep your sun exposure down. But what does that mean? You have to know what it means. Some people felt that they had difficulties associated with relationships at work. They felt they were letting people down because they couldn't perform, some people at work as before. Some felt that their colleagues were not sympathetic, always off sick. One felt that her bosses didn't take it seriously. I think that might be a particular problem with melanoma at the diagnosis of primary disease, because many forms of skin cancer are relatively trivial. They're not trivial, but they're relatively trivial. And patients express the view that their friends and family, people at work, don't always understand what melanoma is and what it means for the patients. One person actually felt better because he felt that he'd got other things to think about and wasn't complaining to his wife about work anymore. And actually that helped their relationship. So it annoys me, but I don't want to apologise, but I do feel, although I'm wrong to do so, like, oh, I only had skin cancer. You almost feel that you should have a better one. I came third in the race. Shouldn't we have an advert? I think that refers to, a particular emphasis on specific forms of cancer, like breast cancer, where people can identify with, and clearly some patients feel a lack of understanding about their own issues. Some felt that they couldn't tell their family how they felt. They don't want to be someone who's always complaining and always down. Others actually, in this study, those people, we did another study actually looking at people who'd relapsed, and I'm not going to talk about this, but sometimes the people who'd had further trouble actually felt more supported. They felt in some ways warmer relationships with their family had emerged when they were in trouble than before. So there was lots of comments about the clinic. When I go to clinic, I don't seem to be picking up just what the situation is, what will happen next, and actually communicating takes a lot of time, making sure that you understand each other in clinic, you and me as a doctor and patients, and there isn't always that amount of time, and I think people don't always get it. But it's all, Imogen was saying, that it's all about these stages, and we didn't have a clue. But you couldn't ask anybody, go back to them and say, because you don't want to tell people, I went to clinic today and they said stage 3 and I don't know what that means. So clearly, many of these people really felt they didn't properly understand. Some felt that they were seeing the nurse too late. It took 3 months to see the nurse. In Leeds, we always try to have the nurse see the patient on the day, and not in 3 months time. and then there's not enough time as an issue. It's almost a case of, right, turn, right, on the bed, let's look at your leg. Oh, that's fine, poke, poke, poke in the groin for any swelling of lymph nodes, and okay, you're fine, come back in 3 months. I'm sure lots of people recognise that scenario. So the summary about this was that 25% approximately of melanoma patients really worried about the future. It was greater with more advanced disease. It was reported less by men, less by older patients. Worry was worse when it was another thing on top of many other issues they had to deal with, and it was more common for melanoma in unusual sites. The issues reported in interviews were uncertainty about the future, changed body image, fear of the sun, effects on relationships at work, at home, loss of my normal life, doing those things that are normal to us, things to do with going to work regularly, cooking, doing those things that we do every day are very reassuring to us. Well, they are reassuring to me. Being able to work and do the garden and doing things is telling me who I am. And if you can't do those things, then it's an emotional hazard, really, and perceived lack of support from the hospital. Now, some people on the right, this is a diagram that you can find on the net about how stress makes cancer worse. And if you look on the net, you can find that stuff. And there are data to suggest that being chronically stressed can have an adverse effect on your health, but actually it's very weak data. No one really knows whether chronic stress actually affects the cancer, but it certainly is difficult to take, it's difficult to tolerate. So anything we can do to try and reduce that stress is very desirable. And I'm going to talk briefly about a paper by Kneier et al. It's quite old, 2003, but it's basically about the different strategies that people use. So what we're trying to achieve after a diagnosis of cancer is a sort of balance, is what he argues, that it's important to know where you are. It's important to have a proportional degree of anxiety, but it's a question of balance. And his point was that the healthcare professionals play a very important role in helping patients to that sense of balance. It says that people take different approaches, and one is facing the reality of one's illness. So some patients at one extreme they want to confront the full reality, they want to know absolutely everything, and some people deal very well with that, some people don't. And then right at the other end, you've got patients who really don't want to know anything about it, and to some extent he describes this as denial. As I said, I'm talking about this, but I haven't had cancer, and I'm only talking about what I perceive to be experienced by patients. So you can tell me later if I've got it wrong. But sometimes my experience is that patients who, after a diagnosis, really want to know all about it, and they have a period of great stress while they get their head around it, but then actually in the end, the majority of those patients do better psychologically. And some patients put it in a box somewhere, and they honestly don't seem to worry about it. And it's the patients who do something in between who really find it difficult, where they try to put it in a box and it keeps coming back. Now, this is about primary disease, not later on. So I'm really just talking about that. Maintaining hope and optimism is reported to be associated with better outcomes. And there's a huge study just been reported about health generally, saying optimistic people live longer. Well, I don't know what that means really. Are they optimistic because they've had an easier life, or is optimism a positive thing? I think it is. But if you're not an optimistic person, it's quite difficult to feel optimistic all the time. And some patients actually feel stressed that they're not optimistic. They feel they ought to be able to triumph, like you see on the net or on the TV, but not all of us can do it. As I said, they feel guilty. They cannot be optimistic always. Some people feel it's wrong and dangerous to be optimistic because something might happen. in the end, I used to say this sometimes in clinic, expect the worst but hope for the best. And I don't know, sometimes that helped and sometimes it didn't. But I think patients facing real difficulty sometimes do better if they get their heads around it, do their memory boxes, those sorts of things, and then they can put that behind them and move on. And for other people, that would be an anathema. It would be terrible to do that. So it's a very individual thing. Generally speaking, people who can express their emotions do better, partly because you can get better support, but some people are just not practiced in looking at their own feelings. Some people just find it very difficult to do. There was an interesting comment, I thought, that if healthcare professionals trivialise a patient's distress, then that patient learns to avoid expressing that distress. It's a sort of message. If when you say to the doctor, I'm feeling really, really stressed, and they say, oh, you'll be fine, or they dismiss it, then it is saying, you can't tell me about your distress, actually. And in our society, men might find this more difficult. They do find it more difficult, in my experience. Now, I'm just reading this book by Grace and Perry, The Descent of Man, and it's all about how we train little boys not to be to express their emotions and things like that. It is a great book. It really is a very good book, and the front amuses me no end. Just look at him. So it's maybe that men find it difficult to express their worries because we've taught them to do. I do think little boys and little girls are different. Personally, having had both. My little girl's never kicked anything, but the boy certainly does. So I don't know whether that's taught or innate, really. No. And this basically is finally about reaching out for support. It's about where do you find help. It's about specialist nurses. Sometimes in many clinics they're overstretched, but specialist nurses are a key point. The next. But be careful what you look at, and local charities try to do their best. It's much better, I think, to look at those British charities for information. And I think it's very good to take control. I think this is like Imogen. And I think that's right. And I think she does a brilliant job. And I think trying to take control is important with the caveat that not everyone can do that. I think that taking exercise, healthy diets, no smoking is part of that, and I believe that might actually have an effect. And I think I've really run out of time, haven't I? 3 more minutes. Okay, so counting one's best blessings and spirituality is another way that some people find relief. And some people actually write down on one side of the paper things that are good and things that are difficult to try and get some sense of balance. And faith helps some people. And even when it's difficult to understand why a loving God allows these things to happen when bad things happen to good people. That was in a book by Rabbi Kushner. So some people take that approach. So I'm talking about empowerment, making some people feel better, expressing their emotions makes some people feel better. Varying approaches to understanding what's happening to them makes them feel better. Counting one's blessings makes some people feel better. I think loss of body, your own body is changed, and inability to do things, as I alluded to earlier, that make you feel like work, like running, like being independent. They're problematic, but actually hanging on to that normal life is really important. So it keeps cancer in its place, as it were. Some people actually take on new things that give them a new sense of self-esteem. There was a television program quite recently, I think it was on the BBC, about a number of people of all ages, different genders, who were given a diagnosis of terminal cancer, and how they absolutely changed their lives. They lived in a different way. And as I said, not everyone's capable of doing that, but finding something else that makes you feel more like you. She stood in the storm, and when the wind did not blow her way. She adjusted her sails. So it's about adjustment to these things. And finally, for patients with advanced disease, there's the issue about how close one should be in terms of coming to terms with mortality. But certainly patients who can come to terms with it achieve some sort of peace. So preparing for that helps some people, but not everyone. And there are lots of websites like that one about how you rationalise these things. I think chat rooms on the net can help a lot of people, not everybody. Support groups can help people, but not everybody. Some people don't like to bear their emotions. Others do. But cancer.net has information about the issues I've talked about, really, and how to access help. So we'll move on now to the next talk. It's Dr. Neil Stephen, who is a medical oncologist from Birmingham. You've not come so far.